This episode of the Berry Chronicles is proudly brought to you by Bariatric Support Australia.
Hey everyone, so we're here with Dr. Roy Hopkins. We're so excited to have you, Dr. Roy. Thank you for joining us. Do you want to just start by telling us a little bit about yourself and the sort of procedures that you do?
Well, thanks for having me on again, Damitesh. I really appreciate it. I'm an upper GI surgeon based in Sydney, and I do weight loss surgery, but I also do what we call esophagogastric surgery, and I specialise in reflux procedures, cancers, and general upper GI surgery as well. So I've got a real interest in reflux. That makes up a lot of my practice, hiatus hernias and anti-reflux surgery, but also weight loss surgery.
And reflux is such a huge thing for so many people after they have their weight loss surgery. I know I've had my own horror story with all of that. So it's something that is actually quite close to my heart.
Yeah, look, I mean, if you look at worldwide statistics, they say 15-20% of the world suffers from what we call GERD reflux. Same thing, really. So it is really prevalent, and even more so, and the symptoms even more worrying after weight loss surgery for a lot of people.
So what actually causes reflux, and what is reflux? You know, some people, you know, they get a pain in their chest and they're told that, you know, you've got reflux. Or I've had other people, even my mother-in-law, she has a CPAP machine and she'll wake up and it's full of bile and all this sort of stuff. So can we talk about just what it actually is?
So reflux is the physical movement of contents from your stomach back up your esophagus, your gullet, your windpipe, and it's the feeling of that. And that can either be a sensation that you get or side effects or complications from that. It can be minor, it can just be pain and irritation. It can lead to inflammation of the bottom of the esophagus. If you get volume coming up, some people can get ongoing respiratory infections. If it comes right back up into the mouth, it can affect dentition and teeth as well. So it's a huge spectrum of just a little bit up to a huge amount, and there's lots of different complications. If you look at, you might have heard of Barrett's esophagus or reflux esophagitis, and a progression between normal tissue and altered tissue, and there's links to cancer as well. So it's a huge spectrum of things. What causes it? The way I describe it to people is your stomach sits in your abdomen and is away from your chest, and it's kept in place by a diaphragm, but it's actually really kept in place by some muscles that come up and around the bottom of the esophagus, and we call that the hiatus crura. There's lots of different words for it, but it effectively locks your esophagus in place. And by doing that, it keeps your stomach in your abdomen. There's also another little muscle in the bottom of the esophagus called the lower esophageal sphincter, which can close and open and relax and lets food come down and stops coming back. And the two of those mechanisms overlie each other to stop reflux. And you know, for many years, people were not quite sure how much they all contributed to it. General consensus now is that actually the hiatus and keeping the stomach in the abdomen accounts for about 70% of the anti-reflux mechanism, and the lower esophageal sphincter itself accounts for about 30%. It varies in the literature, but that's kind of global thought process. And so those two mechanisms together can keep all the contents of the stomach, both the acid, and there's always a little bit of bile that can flick back from the small bowel into the stomach as well. So it keeps all of the contents of the stomach in the stomach and not impacting the esophagus. So that's what it is. Why do people get reflux? A lot of the time it's an anatomical thing. It's a structural thing. If those muscles weaken and you get movement of the stomach up into the chest, that's called a hiatus hernia. And that, depending on the size of that, you can have lots of other problems after that. If it's small, it's usually just reflux. As it gets bigger, you can have other problems like lung problems, compression on the heart. It's really big. I've fixed some ones where the entire stomach's up there. So it's really a spectrum. And so that's a lot of the anti-reflux mechanism weakened by that. Some people also have just a weakened muscle there. And so you've really got to identify what's the cause of it and how to fix it. So how do you usually diagnose it? Well, you do a gastroscopy and see if there's any inflammation there, take some biopsies, see if there's anything going on. If they've got a hiatus hernia, you go into the stomach, turn the camera back around, you can often see the size of the hiatus hernia. You can do a CT scan to see how big it is. If there is no hiatus hernia there though, there's other things you can do, like what we call a pH and a manometry study. Someone has a tube down their nose for 24 hours. It's not particularly comfortable, but that measures the amount of acid and reflux and volume that's coming up as well. So you can tell objectively that someone's got reflux. A lot of times we have subjective feelings of reflux, like I think I've got reflux or heartburn, but that, if you don't have any anatomical problems, gives you objective, independent evidence that that's what you've got. And then when you've got those all together, I can have a meaningful discussion with my patient about, have they actually got reflux, what's caused it, and what the best thing to do for that is. If they do have reflux, we can generally offer them what we call either a hiatus hernia repair, if they've got a hiatus hernia, and a fundoplication where we can wrap part of the stomach around it. And there's lots of ways you can do that, lots of different ways in the world, in the literature, and everyone's got their own way. I've been taught a particular way. I do an anterior wrap because I think it's better. But that's how we treat normal reflux problem. A lot of people that can be on, I'm sure you've heard of a proton pump inhibitor, the medications, and that can control it for some people. But even when you're on high doses for some people, you have ongoing problems, and that's when we get involved.
Wow. So, why do you think? Because in our support group, we have a lot of people that have had sleeve.
Yeah.
And it almost seems that there's more cases of reflux becoming an issue after they have the gastric sleeve than, say, some of the bypasses. Well, is there something that sort of weakens that, or might, cause
Yeah.
that with the sleeve?
Yep. So in a sleeve, if you look at what has happened during a sleeve, your whole stomach is still present. And then you've taken off the large part of the stomach, the fundus, which is the bit that's able to distend. So you've got a thin, narrow muscular tube rather than one that could expand before. So you've got differences in expandability, you could say. And so there are some studies that show there might be some increased pressure within that sleeve. That in itself isn't usually a problem. We all know how to make a good sleeve, how to avoid that. You need to have a particular distance out as the stomach goes round and around the corners, a thing called the incisura, and we know you need to be about 4 centimetres outside that to stop that. If you have a narrowing of your sleeve, then you can have problems as you get back pressure coming back up. But other problems are if you have then a weakening of that hiatus I mentioned earlier afterwards, because you've got no attachments holding the stomach and the abdomen, it's a lot easier for it to move up and telescope up into the chest. Now, after a sleeve, if you get that, we can tell either on endoscopy, but on a CT scan, you can tell it's what we call intrathoracic migration, or ITM. You can see it on a CT because you can see the staple line up in the chest.
Oh, wow.
And that means that they've lost that ability of the hiatus, the anti-reflux mechanism. The other thing about a sleeve is that we know how close you can staple to the bottom of the esophagus normally. And if you've taken that part of the stomach off, there's not so much of an acute angle there anymore. It opens up a little bit, and there's some thought that can also increase reflux as well. For most people, it's not usually a problem. But obviously, as people progress along their journey after having a sleeve, people say after a few years might get even more reflux. Often that's a bit of ITM, or migration of the top of the sleeve into the stomach. And you don't have the reflux ability after that, the anti-reflux ability after that. So really the best thing to do for that is to investigate it, to go back to your surgeon, do a gastroscopy, do all the investigations to see if you do have problems, and if you don't and you've still got reflux, you can do a pH study to see if you've got acid or volume coming up. And if you do, we can surgically fix that. You can do a hiatus hernia repair. And funnily enough, people say, can you do a fundoplication after a sleeve? You can't do a full fundoplication most of the time, but you can often take a little bit of that sleeve, that staple line, and wrap it round or increase that angle again. Conversely or counterintuitively, if you have had a little bit of sleeve dilatation, you can also use that to your advantage and just kind of wrap it around, or I do, and I've had good results from doing that.
Wow.
But that's usually kind of what it causes, and that's how we deal with it most of the time in a sleeve. If you think about technical problems with the sleeve, is the sleeve too tight in the first place? Is there a narrowness, stenosis? If people have had to go back to the surgeon and get get a balloon dilatation, that might be an indicator they're going to get more back pressure coming up there. Spiraling in the sleeve, just a few technical issues, but most people are very well taught and they do a good sleeve.
Yeah. So is it a case of a bypass is better?
No, I don't necessarily think so. I think the right thing is, my mantra as a surgeon is the right procedure for the right patient at the right time. We all know, I'm sure other people you've had on your podcast have told that there are some contraindications to bypasses. If people have got metabolic disorders, if they've got irritable bowel syndrome, if they're taking medications, I don't think reflux alone or the presence of a hiatus hernia alone should dictate that you have to have a bypass. I do sleeves on people who have a hiatus hernia and fix them both at the same time and have really good outcomes. So I don't think it's necessarily a reason to mandate someone to have a bypass. You should factor it in, but most good surgeons can certainly fix that hiatus hernia at the same time. And so I don't think it should impact on what you're trying to achieve with your weight loss procedure.
Yeah. Tash, you had a bypass and you still get reflux.
Correct.
So it certainly shows there that it's not a guaranteed cure going from sleeve to a bypass.
Yeah, very much so. And if you look at the data from around the world, there's lots of different case studies around the world from different countries, different amounts of patients in those case studies. Some numbers that have been reported as some people, you think you get reflux in 15 to 30% of cases after a sleeve. One big study thought you might get it in 41% after one anastomosis bypass, mini bypass. They've all got different names. Although another group said only 4.1%, and after a Roux-en-Y bypass, this big study said 18%, but others said much smaller. So there's no perfect procedure, and you are still got a proportion of people who are going to suffer reflux or symptoms like reflux, because you have to diagnose it properly to make sure it is reflux. But nothing in life is perfect.
Exactly.
And so I think you need to go in eyes wide open that there are all possibilities. If you want to talk about the different bypasses, we can for reflux. So a common procedure now, or perhaps becoming more common, is the one anastomosis bypass, single anastomosis bypass, the omega bypass, mini bypass. They're all the same thing. Often what you get there, maybe not reflux in the classical sense, but you might be getting bile reflux. And the bile reflux happens because you've got a thin tube that you made as a pouch, but you've just got a loop of bowel that comes round past the stomach, up, loops up, and keeps going. That means that any bile that's come out from your gallbladder and your liver and your pancreatic enzymes just travel around normally, and then they come up, hopefully catch the food, and go back down. But because you've had a bypass, it's not like a sleeve gastrectomy where you've still got the muscle at the end of your stomach which closes. You don't have a mechanism to close. So you have an open movement of anything that's in your pouch into your small bowel, which means you can conversely get bile coming back up into your pouch. It's not a one-way valve, it's a two-way movement. And so what you might be getting is bile reflux into your pouch. And that's and then if you've got intrathoracic migration of that staple line, well, then you're going to get bile reflux up into your pouch and up into your esophagus if you've got any weakness there as well. So you've got an added way that you can get reflux after that one anastomosis bypass. And a lot of people try and make a very long, narrow tube because of that, but then you can still get some reflux. And so some people then complain and want to be transferred or converted to a Roux-en-Y bypass. I mean, if you've had a one anastomosis bypass, same thing. If you think you've got symptoms of reflux or bile reflux, you need to go back to your surgeon and get some investigations.
Absolutely.
A gastroscopy to see if you've got bile in the pouch. How big is the pouch? How wide is the anastomosis? Is there obvious bile reflux coming through? Should get a CT scan. I think a lot of people have heard of a 3D CT scan or a CT fizz. That's where we do a CT and you swallow a compound, and what it does is it's able to expand your sleeve or your pouch, and so we can see if there's any problems with it technically. You can see the shape of it, and so you can see then if you've got a hiatus hernia or not.
I've not had a fizz yet.
No, yeah. People tell me they're interesting to have. I haven't had one myself, but they're very valuable for us because they really tell us what's going on post-surgery. They tell us if there's any twisting. They tell us if there's any narrowing, if there's any pushback of the stomach, migration up into the chest. It's really a very good scan for us to see those things because it gives us a lot more information than a normal CT scan.
Dr. Roy, this is, I think, where our bariatric community really need to understand that sometimes we love our GPs, but when we're experiencing something like this, if our referral to our surgeon has expired, we need to go see our GP and just be referred straight back to our surgeon.
Yeah.
Would you agree?
Absolutely. Look, and you know, we're people, we stand by what we do and we try to help patients. I would far rather someone came back to see me if they're having issues than they soldiered on in the community. I would rather know about it and investigate it properly. I don't want people suffering.
Yes.
That's not what I got into this for.
Yeah.
I want people to
totally
be functional and happy and living their best life. And if I can help them, if there's something that has happened, I would rather be able to give them the opportunity to fix it and investigate it properly to help them moving forward and give them the best opportunity.
So all of these tests that you've mentioned, if somebody just goes in to see their surgeon and they say, I feel like I'm experiencing reflux, then obviously that particular surgeon will have their protocol of tests that they will do. That's correct,
Yeah, absolutely. We all have our own way of doing things, our own thought process, but by and large, you will all get the same investigations or the same sequence of investigations to give the answer. You look at common things first, and then as you rule those out, you look at more specific things. But we all listen to what our patients say. And when I say that specifically, give them the opportunity to tell their story to get the full picture. Because then you can pick up on little subtle things that might be happening that they may not be aware of, but actually are quite important. So I just, have a good chat with them, open-ended discussion, let them tell me what they think is going on, because then I can pick up those little things. And, is it reflux? Is it possibly bile reflux? Is it dumping? Have they got like what we call a stasis syndrome or bowel overgrowth? Or have they got, is it not reflux? Is it even a marginal ulcer? And a lot of people in the groups talk about ulceration at the joint too. Have they started smoking again? Have they started vaping again? Are they taking anti-inflammatories? Are they taking any other medications? Is there something that's causing an ulceration and pain at that joint? Because it's different treatment, completely different problem. And like everything, what you really want to do is find the cause of the problem and then address that cause to improve the situation.
That's excellent.
And I think that's the thing. I mean, they're the things with one anastomosis bypass. I think we'd all agree as surgeons that the guidelines say that if you've got any intrathoracic migration, you should fix that. Like that's like a hiatus hernia repair. I mean, you can't, as I said, you can't wrap the stomach round, but you can pull it all back down and try and fix it as much as you can to improve the situation, and that usually has a good outcome. You were talking about a Roux and Y as well, Tash, and problems that can happen with that, because classically people will think, well, if there's no stomach and there's no joint and it's built differently, so I can't have reflux, how can I have reflux? And you can still have reflux. I mean, the issues you can get is if you've got a slightly larger gastric pouch, you can still make the gastric acid. Is there a slight problem with the way the joint's done? You might have heard something called candy cane syndrome, and that's where you've got the joint onto the bottom of the pouch because they've cut it and the other bit of bowel's down here. But if a little bit is left long or it gets bigger by itself, a bit of food or stuff can get stuck in there, and that can cause problems as well. If people, if heaven forbid, the pouch and the ruminant stomach, if it's still there, if it's a primary bypass is still there, and they can reattach and get a little joint between them called a fistula, you can get reflux back that way as well. Then, have they got problems in the bottom of their esophagus initially? Have they got problems with clearance? Have they got a muscular problem in the bottom of the esophagus?
I'm just back at it reattaching itself.
Yeah,
Oh
so
my God.
yeah. So you can get a what you
Wow.
call a gastric fistula or a pouch gastric fistula. So we use staples and a knife between the staples. It's a stapling machine that we use, and it's quite possible that, and I've seen it, that the stomach that's been left there and the pouch can get close together and rub, or you get a little hole and they join back up. Yeah, I know. Yeah, I know. And actually, that's also a common cause of weight regain, because if the hole gets big enough, then you've still got fluid going through like it did originally as well.
Wow.
So, yeah,
Wow.
lots of
Yes.
I
things
have
can go
now.
wrong.
I have on in our support group, I have seen a couple of people mention that they have had a fistula.
Yeah.
So now I understand what that is.
Yeah. I'd like to say everything's foolproof, but nothing in life is foolproof, and it does happen.
Yeah.
Despite all of our efforts otherwise, even if we reinforce staple lines, things happen.
Goodness me. So yeah, I mean, we often think that if all else fails, just bypass. Or that seems to be like a common thought within the bariatric community from the patient sort of side of it. But it can also have its challenges too.
Yeah.
Obviously.
And what are you doing the revision bypass for? Is it truly for reflux, or is it for weight regain? What is the true motion for doing it? But then also, a revision procedure always has more risks than an initial procedure. I'm not saying go straight to a bypass. Right procedure for the right person at the right time. You could do your homework first and come into an agreement with your surgeon, what I would call a shared decision, a mutual decision between the surgeon and your patient about what the right procedure for them is at that point in time in their life, based on a whole lot of things, their lifestyle, their own history, everything like that. But revision procedures are inherently more risky, so you've got to have the right reason for doing it. And that's the real issue there. You've got to make sure it's the right reason for doing it. If you've got a tight sleeve, or if your sleeve has had problems and there is anatomical problems down the sleeve, like as it goes around that corner there, and you've got what we call a stenosis and narrowing, and you're never going to be able to get that bigger, there's some surgical procedures you can do, but also you could possibly bypass above that to take that out of the equation. Everyone's different, and everyone has their own lived lives. As surgeons, we're people as well, so we have our own lived lives, our own knowledge, our own experience, what's worked for us before and what hasn't worked for us. And so my personal thought is in my hands. I'm very happy to fix a hiatus hernia. I do it routinely for non-bariatric cases as well. So I'm very happy to get up there and fix that, because I think it has a good effect. But each to their own, or each to their own thought process of how they think the outcomes differ.
So there's a term that gets thrown around a lot that we hear: silent reflux. Have you heard of that? Have you?
Yeah. And I get patients who get referred to me, both who have had weight loss surgery and who haven't had weight loss surgery, who have maybe silent reflux. Silent reflux indicates reflux that doesn't have the classical symptoms. So they may not be experiencing heartburn or feel volume, or what we call water brush, where you feel that horrible acid coming up your throat into the back of your mouth. It's truly symptomatically silent, but it has complications. I have had people refer to me because they have had ongoing respiratory tract infections, because they're getting volume up that they can't feel coming up through and dripping down into their lungs, or people who have got ongoing sinus infections, or people who have got dental problems from the acid and the bile and the other stuff coming up, washing around their mouth as well. And so it's all really important to listen to the patient again, what other things they might have going on, and then investigate it properly. You remember I spoke about what I call a pH study, maybe a manometry study earlier. That's a really good way to see if someone has silent reflux. Well, first of all, you would do a gastroscopy to see if they have any changes. What I would say, changes we can see with the naked eye when we go down with the gastroscope. Have they got inflammation? Have they got any changes you can see, and then we might take some biopsies to send it away to a pathologist to see under the microscope, have they got any problems going on? But then if there's nothing then, I might send someone to one of my colleagues for a pH study or manometry. And so what actually happens is you have a little tube stuck down your nose, and it sits down, and the bottom of that tube sits just above the sphincter that I spoke about before, or as it goes into the stomach. And most of these have multiple little reading channels on them now. And so you have it down for 24 hours, and most people do complain bitterly. I understand that. It's not entirely pleasant. But what it can tell you is, are they actually getting reflux up? And a lot of the time we ask them to have a little button, and they push it each time they think they have reflux as well. And so that can correspond, and you can tell if they're symptomatic, if they're feeling they've got reflux or problems, or they've actually got true reflux. There's lots of things we can do, and we look at a thing called a domestic score, which it's a score manufactured by multiple components of the readings of that study, and there's some defined variables for that. But that will often tell us if someone's getting volume reflux or acid reflux up as well. And that can really help. And it really is life-changing, actually. I've had patients who've come back after that, and their chronic cough is gone. And, they're able to breathe better, and they have, that means they're more active. So from a lifestyle point of view, most of my patients who have that are very, very happy, and it really has done them a lot of good. But that's what silent reflux is. It's the fact that you can't feel it, but it's still happening. And so you need something to tell you that it is actually happening.
So with silent reflux, because I suspect that one of my sons has it, because he's right from when he was quite young, he's always had this funny little cough, and it doesn't respond. Like, people used to think that it was asthma, but anyway, over the years we've thought that it is possibly reflux. Is this just some sort of a functional thing inside that people can just be that way?
Yeah.
How does it?
Yeah.
So genetically just predisposed?
That is a very complex question. A lot of things we might
Of course it is.
we may have on a heartbeat. I've got a master's in genetics. So I think a lot of those things, there might be a structural problem, an anatomical problem if they have a hiatus hernia, but if they don't, and if you want to talk about genetics, like a lot of things in life, you might have a genetic predisposition, but then you might have environmental factors that play a part as well. And so I don't think it's a black and white.
Yeah.
In fact, we all know there's very rarely a black and white to everything in life. Everything's a shade of grey, and everything sits somewhere on that spectrum.
Yeah.
That sounds like a very wishy-washy answer, trying to get out of it. But I think that's the real answer to that.
No, it doesn't.
What you can tell, though, is what you want to know. If someone's got silent reflux, you want to know, have they got a problem anatomically? Have they got a hiatus hernia first? If they don't, then have they got a weakness of that muscle, that lower esophageal sphincter at the bottom? And have they got reflux coming up? And that's where you do, an endoscopy or a CT scan, and then progress on to something like a pH study or a manometry study to see. A manometry study is a study that we can do where you have, a tube down your throat, but you take a sip of water, and that has different pressure monitors on it going down, and that can tell how well your esophagus and the muscles in your esophagus are pushing things down in waves.
Right.
And we can look at that, and there's problems. Something called achalasia is a classic where you lose that ability, but you want to know how well their esophagus, how well is their ability to push things down to start off with. And so that's what a manometry does, and it tells us.
What's up with these tests?
Smart people. Smart people. Very, very smart people who wanted to look at these things.
Credible people that work this stuff out.
Yeah, and look, they are specialised tests. They're not something everyone does, and they're not available everywhere.
No, they're not. And we know that because I know that Damo has required one of those particular tests, and there was nowhere locally, was there?
No, even a fizz, CT fizz,
Yep.
It's
Yeah.
It's a go to Melbourne.
Yeah.
Yeah, because you guys are in Victoria. Yeah, look, I'm in New South Wales. Same in New South Wales. A lot of these investigations aren't available in more rural centres,
Yeah.
outside of Sydney, maybe Wollongong, Newcastle. I don't know. Oh no, there is some. I think you can do it in Albury. There's some people down in Albury who do it in Wagga. But if you're living outside those centres, I mean, it's very hard to organise. You've got to
Yeah.
refer them onwards, or or we need to know where they live and find someone local to them that we know.
Very, very important if you are suffering from any of those symptoms to go down the route and commit to the process of finding out what's going on.
You can't find the right solution if you can't find the cause a lot of the time. And so you need to commit to the process. That sounds very high and mighty, I understand that. But if you at least commit to the process of working through any problem you have medically should be worked through logically. And then you rule things in or you rule things out, and that will inevitably steer you towards hopefully the right answer.
I think that's why it's so important that we do have these types of discussions, because we also understand that a lot of people have sleeves, have mini bypasses, have bypasses and are fine.
Yeah.
But if you're not fine, then it's
Go and see someone.
important to know what the procedure is, but also for us to be aware that if we have one of these procedures to help with our weight, that we may in time require some other types of interventions, and it's being committed to ourselves enough to know that, okay, well, that could happen to me, and that might be something that I would have to be committed to.
Yeah, absolutely. It's like throwing a stone in a pond. Everything has ripple effects. And to think that you're going to have a stone that throws into a pond that's not going to splash, that is going to be a perfect magical unicorn drop into a pond, may not be entirely correct.
Yeah.
And I think
I totally agree.
Listening to your body, knowing when things aren't going right, and thinking, something's not right here, I need to go and get this looked at, and making an appointment with your surgeon, or you start off with your GP, referral back to your surgeon, or people who can investigate it for you. That's what we're here to do. We are here as medical practitioners. Our role in life is to help others and help them get better and feel better.
That's great.
Because even just, someone might have reflux and they're on whatever medications for it, but even that can have long-term effects as well, I guess. And
there's a lot of postulated issues with PPIs, and I'm sure most people have seen that in the media. There's some thought process around it. Is there any guarantees? No, but then if you took someone off a PPI who's got reflux, because of those, and they became really symptomatic again, what's more important to them? So, there's issues with most things in life, and these PPI medications have been around for many, many years, and, problems are coming to light now, years later. It's the same thing with lots of things. We do things now that we think is the right thing, and we do it with the knowledge of society and where we've got to. But will that change in the future? Possibly. But we've done it with the best interest in mind at present.
Unfortunately, we don't have crystal balls.
Not Harry Potter.
No.
I don't have a crystal ball. I don't have a wand. Love to. Love to.
Me too. Would love to know, but
I don't have a TARDIS. I can't go through forwards and backwards in time. I don't. What is it? The multiverse. Be great to see if what action you did now. If you could sliding doors moment, multiverse. Where would that go? Don't know, but we live one life.
Yeah, that's right, and that's why it's so important that if we are experiencing any of those things, that we do actually take steps to find out what's going on and have the appropriate treatment, because we just only live one life.
Yeah,
absolutely. I would far rather people came back to me for any problem so I can talk through it with them and investigate it if I need to help them. It really is important. Yeah, I don't want people suffering out there in the community. I'd rather not.
If we speak to our surgeons about it, then they're usually up to date with the most recent studies on these issues. So we're not going off information that could be 10 years old, or because we're asking the wrong person for advice.
No, look, we all have continuing professional development. As surgeons, we have to have that component. We have to have it for our yearly registration. We have to demonstrate it. So we should all be up to date.
That's very important to
So,
know.
what would your favorite procedure be?
Interesting question. I'm a simple person, Damo. I still like a sleeve. I think a sleeve does most people well. Look, I work with quite a few people who live more rurally, so I'm looking for a safe procedure if that's the case, or without multiple side effects. And if you look at the data, you're looking at maybe a 3 to 5% total weight loss difference at 4 years at the moment, according to registry data. But I personalise it for every person, and it depends what they want as well. If I have a young lady come in and who would like some weight loss surgery and she wants to have children later on, I'd probably be more hesitant to offer a bypass. I think a sleeve is probably better at that point in time. If people come in with medical complications, or it's not very often you come in and see someone who wants this procedure who has no comorbidities.
Yeah.
And so I'm trying to find the right thing for them. And what's important to them. What do they want out of the situation? I offer advice, but ethically, I make a shared decision with all my patients, and we discuss it. We discuss what the outcomes of the procedures are, how they work differently, what they would need to do afterwards to maintain that, and what everyone's got to put effort in to keep going on the right journey, and what it means to them, and also what their dietary habits are, and other issues like that. So it does kind of depend. I'm led a lot by my patients, to be honest.
Yeah. Do you find that you have a lot of people that they might be on some slow release medications and that does that add another layer of complexity to?
Yeah. I take a very careful and detailed medical history and look at the medications everyone's on and look at the reasons they're on those medications. Have they got anti-epileptics? Well, they're absorbed in the proximal bowel a lot of the time. Are they on blood thinners? Particular blood thinners are also absorbed there. What other medications that come to mind? Or conversely, what other medical issues do they have? Do they have anything that's going to alter inherently their absorption of nutrients? Have they got any problems with their small bowel already? Because that will also make a big difference as well. If you're going to bypass someone they've already got lesser ability to absorb things, then you're probably heading down a slippery slope to trouble.
Could we circle back for a second, because I've just had it in thinking. When it comes to the revision procedures that you offer, and or for reflux specifically, is there much data on how effective those types of procedures are on people that have had bariatric surgery and are experiencing reflux, how they go after they have those procedures?
So in terms of the conversion, specifically? Okay. So if you go back for anti-reflux procedure, you'd like to say that you could do a repeat pH study, but a lot of people won't tolerate another 24-hour pH study, and that is a major lifestyle issue. And if you look at all the data around the world from upper GI surgeons about how effective is their procedure or their fundoplication, a lot of it comes down to that. You've got to have a patient who's willing to come back to undergo a not particularly pleasant investigation again. So most of the time, we rely on symptom control or their symptoms. If someone if someone has a hiatus hernia and has that fixed, there is a recurrence rate, and that varies in the world, somewhere between 7 and 15% for re-weakening of those muscles. So I rely on my patients to come back and tell me if they've got any issues. But just if you've had if it's for reflux only, you can do a gastroscopy. You can see if they've got any inflammation again. But if it's silent reflux, how are you going to tell that physiologically? If they're asymptomatic, you'd have to do a pH study. Most people probably aren't happy to have that.
sorry to just throw that one on you,
No,
but
that's a really important question because people want to know, well, how effective is it? How will I know if it's effective? And what if I don't have symptoms?
like
Well,
if I'm going to, because obviously if you've gone down the route of bariatric surgery, you've already put yourself through a lot, and then you're putting yourself through another procedure in the hopes of getting better. It would just be great if there was some sort of metric that we could say, well, generally, and you said, generally speaking, was it 7 to 15%?
no, that's for a recurrence, for a normal hiatus, not after a bariatric procedure. That's normally. Look, and there are long-term data. Most of this data does come from people who haven't had bariatric surgery, if we're talking about anti-reflux data. And, there's long-term studies. I've published a 10-year study, and we found that 80 or 90% were very happy they'd had the operation in the first place. So, look, anti-reflux surgery in general for the general population is well tolerated with an excellent outcome. We've got really good data that shows the vast majority of people are very happy they've had the procedure, and it really has improved the quality of their lives. So we take that and move across to people who've had weight loss surgery. If you've had a sleeve, we know that by reinforcing that hiatus again, and maybe just fixing up what we call an angle of His, you can improve their symptoms a lot. But I would probably rely on their symptom control after that to tell me.
Yeah, no, it's really, really good to know, because again, it's just one of those things that's asked quite a lot. If I go through all of this, will it improve things?
We always do things in the hope that it improves things, and with our very best intentions.
Yep, that's right.
Obviously, sometimes, despite best intentions, and even in the best hands of the best surgeons in the world,
that's right,
you don't get a completely optimal result. But that is the nature of life, unfortunately.
No, it is.
That sounds very fatalistic, I know.
And look, well, as soon as we start any type of intervention, any type of surgical intervention, I knew going into my surgery that I was very well informed that by having this surgery, then there will always be that risk that I will require further surgeries down the line. So I think it's just something that we need to be aware of.
And that's something I certainly discuss with all my patients, and we should be, and part of what we call the consent process, we talk about complications that might happen. And we're really lucky with the BSR data now. We've got really good parameters that we know the risk profiles in different procedures are, which is great. That's really good data to have, because that's local data. So we can have a meaningful discussion with our patients. So that is good local data. What is it? I can't remember the exact figure, but it's 160,000 people in the database now, isn't it? Or more.
Yeah.
I want to say a specific number.
100
Exactly right. So I'm not going to.
I don't remember exactly how many, but yes, I mean, it's good and meaningful data. It's Australian and New Zealand data.
Yeah, so we know what the risk profiles are. And so I will always tell my patients and talk through those risk profiles and what can go wrong. And I will always give them the BSR data sheet to take home with them.
Yeah, no, that's awesome. Thank you for answering that. I know that, like I said, out of left field, but...
No.
I think it's
a good field question. It's fine.
I think it's a good discussion, though, because I know, sort of... And I guess we still see people that are led to believe that you can't get reflux after a bypass. And, when I know what Tash has been through and other people that I know that have had bypasses, it's a bit of a scary thing when you hear someone say, "Oh, I'm going bypass because I don't want reflux." And it's like, you could really be opening yourself up to some disappointment and not even realise it.
I agree completely. I don't think choosing your procedure based on the likelihood of reflux afterwards as the sole determinant of what procedure you choose is the right way to go.
Yeah.
It really needs to take everything. I mean, for me, I had a very high BMI, and that was really, I think, primarily the determining factor in the surgery type that was chosen. That I ultimately did make the decision, and I don't regret having made the one that I made, I'm very, very happy with all of that. But I also do accept the fact that I've had complications as a result of the choice that I made. And it wasn't
Yeah,
informed choice.
look, I agree. I think anyone making any decision in life, whatever that is, needs to think of the possible consequences.
Mm.
And I often ask my surgical trainees about hard decisions they've had to make. And it's really interesting to see how people come up with those, what are the possible complications or consequences of this decision. A good decision is one that's made knowing the possible issues, complications, or long-term events that might happen afterwards, and taking those risks into account.
Yep.
And making a judgment decision of what you as a human being are happy to live with the risks for.
That's exactly
and
right.
therefore you go into surgery or any decisions you make in life with eyes wide open.
One of the things that, and I know Damo will completely agree with me on this, that I don't like to see is when people say, "Oh, I'm letting my surgeon decide." Your surgeon does not have to live with
Your decision.
with the
Right.
body that you were left with afterwards. So I know from speaking with you on other occasions that you firmly believe that it is a decision that needs to be made together,
Yeah.
but in the best interests
Yeah.
of the person
Yeah.
that is going to have the procedure.
I think my own personal philosophy, and it's my personal philosophy, is I've not walked 500 miles in another person's shoes. I do not have their lived experiences. I haven't got do not live their life on a day-to-day basis. I let them tell me what's important to them, what they need, what they're looking for, and then I tell them what as a surgeon, I or we as a craft group can offer them, and try and be pragmatic and practical about trying to address what their issues are. And then we talk about the variety of procedures available and, the likely outcomes, the possible complications, what people need to do, the bariatric multivitamin they've got to take, other things that might happen for each procedure. And we talk about everything globally. And then we have a discussion about the pros and cons, what's important to them, what's not as important to them. And generally, by the time they've had that, they've got an idea of what they want. And I'm usually happy to kind of go with that. But if I think it's not an appropriate thing, I will jump in and I'll explain why. I always explain why. If I can give the ancient proverb, give a man a fish, feed him for a day, teach a man to fish, feed him for a lifetime. If I can give good quality information, good quality education, people can understand my thought process as, I would hope, an experienced and learned individual.
Amazing.
And then we take all that into account and make a shared decision about what the best way forward is.
Dr. Roy, thank you so much for joining us today.
You're welcome. It's always a pleasure.
This has been a great chat, and I'm sure that people are going to get so much out of this.
I hope so. And just the only thing I want to implore people is if you're having symptoms, please go back to your surgeon. Please let them know. We don't want you suffering. And if there's something we can do to help you, we will do that.
Yeah, brilliant.
Yes.